Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami, and welcome to our Monday afternoon Instagram chat. Today's topic is what sparks your chemistry when couples are faced with infertility, female factor, male factor, or both. In other words, what makes it work, what makes it not work? Why am I infertile? Why am I having a problem? Whose fault is it? Obviously, to get a pregnancy to work, we need a healthy egg, a healthy sperm, a nice place for the embryo to implant, a healthy uterus, and that's what sparks the chemistry, basically. All three of those things have to be present. So when couples come to us, they're approaching us, why aren't I getting pregnant, or am I going to have a hard time getting pregnant? What do we need to do, and what do we need to evaluate? So in essence, we need to, usually within a very quick manner, within a month, we can assess a couple completely to determine what factors may be responsible for making it more difficult to get pregnant, and give us an idea of what direction we need to go into treatment. So, in essence, we've got male factors, female factors, a combination factors, and then a lot of times we have unexplained infertility where we've done our basic testing and we can't blame anything on a single thing, and in that case we have to just treat the couple for unexplained infertility. And it's important to get a diagnosis if we can, because then we know how to aim our therapy directly at what's not working. For instance, if a woman's not ovulating properly, not having a regular period, we can use an ovulatory drug, and often that's all we need to fix things. If a tube is blocked, then obviously we can talk about bypassing the tube or fixing the tubes. If the sperm's not normal, then do we fix the sperm or do we use the sperm we have? So let's break it down into male and female factors. On the male side, we want to know, is the sperm okay? The simplest way to do that is with a ejaculated sample of sperm. We do a semen analysis. And with that, we look at the count, motility, and the morphology of the sperm. And that gives us a pretty good idea of whether we would expect this sperm under normal circumstances to be adequate enough to get through the cervical mucus, find the egg, fertilize the egg, and so forth. If the sperm is suboptimal, then we may do some hormone tests to measure testosterone, FSH, LH, TSH, and prolactin on the male side. And if the sperm counts are very, very, very low, then we may do some genetic testing with karyotypes and Y chromosome microdeletion testing to see if there's an obviously explanation. If sperm counts are low, we'll often recommend a urologic exam to make sure there's not a varicocele or other urologic issue, and that is simply how we deal with the men. Women are a little more complicated. We have to look at multiple different aspects, but they break down into a few basic principles. The first is, do I ovulate properly? And if you're having a regular cycle with an ovulation predictor kit that's turning positive mid-cycle, that's pretty presumptive evidence that you're ovulating okay. We can look at a temperature chart, which will be elevated in the second half of the cycle, or more specifically, look at a progesterone level around day 20, 21 of the cycle, and the latter will give definitive evidence that ovulation has indeed taken place. Most of the apps that you have on your phone that are menstrual cycle trackers and ovulation trackers do not really give you any scientific prediction of when ovulation is occurring, but it's just going to tell you about when you're in the middle of your cycle. And that's, usually you'll ovulate between 12 and 14 days prior to the next period. So what most of the apps do that do not involve testing anything, they're just looking at when did you get your periods. These apps really just predict when it thinks you're in the middle of the cycle and when you should be fertile. But to test whether you're going to ovulate or not, you really need to use an ovulation predictor kit. And to confirm that ovulation's occurred, you either need to use either a temperature chart or just get a progesterone level. The second aspect on the female side is the anatomy. And with that, the two major factors other than a physical exam are ultrasound and hysterosalpingogram. An ultrasound will tell us if there's any fibroids present, if the ovaries are in the right location. If the ultrasound is done early in the cycle, we can also measure antral follicles, which are helpful to predict ovarian reserve. And the hysterosalpingogram is a radiographic test where the radiologist will inject a radiopaque dye through the cervix, and you can take a picture of this dye going into the uterus and out the tubes, and that will confirm that there's a normal shape to the uterus and both tubes to be open and patent. And the third key piece of information on the female side is what's called ovarian reserve. And ovarian reserve is just a concept to tell us, do we think this ovary is going to be responsive, it has a high collection of eggs, or is it kind of at its tail end of its reproductive life? Does it have a limited number of eggs present? And if we stimulate this ovary, are we going to need a lot more fertility drugs in order to get the same response out of the ovary compared to somebody with better ovarian reserve? And that's basically it. It's not that complicated in that we just have to look at the basics. Again, on the male side, sperm count. Is the sperm okay? Are they moving? Are they normal shape? On the female side, the three key questions are, does ovulation take place? The second question is my anatomy acceptable? And the third question is, do I have good ovarian reserve? The next part of the conversation is, okay, once we get the answers, what do we do? And it depends what we find. If ovulation is not occurring, we fix ovulation by using ovulatory drugs, whether they be oral fertility drugs or injectable medications. If we're dealing with a suboptimal amount of sperm, then we're left with usually two alternatives to assist that sperm that already exists in working better. And the two options are either what's called artificial insemination, otherwise known as intrauterine insemination, or IUI, where the sperm is placed up into the uterus, usually in concert with using an ovulatory drug. Or if the sperm is significantly compromised, then in vitro fertilization, where we can achieve fertilization of the eggs, not by just putting the sperm in the same dish of the eggs, but by, under the microscope, identifying sperm and injecting a single sperm into a single egg with what's called intracytoplasmic sperm injection, or commonly referred to as ICSI. If there's anatomic disease on the female side, then the question is it easily fixable? And if you fix it, is that going to significantly improve the chances of pregnancy? Or are things so damaged that even if you try and fix things, odds are you're not going to get much of a benefit? And so you always have to balance the benefits of surgery and then sitting on one's hands, the need for surgery before we do something else, such as if there's a big cyst in the ovary like endometrioma or a dermoid or a hydrosalpinx, a block tube. Those kind of things might prevent us from even doing IVF as a treatment. So we've got to balance, do we do surgery or do we do in vitro fertilization? And in vitro fertilization, remember, is a multi-step procedure where initially you're placed on injectable fertility drugs to try and produce multiple eggs. The eggs are aspirated by ultrasound guidance in the middle of the cycle, fertilized in the dish. The embryos are allowed to grow for 5 to 6 days. The embryos that result are called blastocysts. These can be biopsied to make sure they're genetically competent, and the healthy embryos placed back into the uterus on an additional cycle. And the last two categories, one is when you get a combination of things. And often when you have a combination of things that aren't right, IVF is the best approach because it bypasses them. And then you have the grouping of patients that fall into this unexplained infertility category. And with unexplained infertility, it just means all the things we just spoke about. all are fairly normal or minimally abnormal. Nothing really explains why the couple's not getting pregnant. And in that case, we'll sometimes see some success with intrauterine insemination combined with a fertility drug. But if not pregnant within 2 or 3 cycles, it's recommended quickly to move on to much more successful treatment, which in this case is in vitro fertilization again. So, the key is find out what's wrong, try and guide our therapy directly if we can. Sometimes it's a matter of trying A or B, and if all else fails, and in many cases the first approach should be in vitro fertilization, depending on what exactly we're treating. So that's how it has to work in order to get it to work. I hope that it's a brief summary which is informative to people. And if you go through some of the past Instagram chats, you'll find all these different topics of IUI versus IVF and Ovarian Reserve and so forth, semen analysis, evaluation. We've chatted about most of that stuff, so feel free to go online and check out what we've talked about before. And particularly if you have a particular topic you'd like us to address that we haven't, please email us and send us your feedback, and I'm happy to focus some of our future talks on what many of you are concerned with. So thank you for listening in. I hope this was somewhat helpful, short, succinct idea of what it takes to get pregnant, and we're here to get the chemistry to work for you when nature doesn't want to do it alone. Have a good day and stay safe. Bye-bye.